So yeah, my name is Rachel. I'm the director of admissions here down at Aspen Grove. I've been doing it for about 6 months. As Joseph was saying, I have kind of held a lot of different positions in the behavioral health world, and I feel like it's been really beneficial for me because I can see a little bit of all sides of things. So today we're going to talk about navigating levels of care. I think one of the biggest takeaways from this presentation that I'd like for people to get is just understanding that there is a lot out there. There's a lot of people who are not sure about what might be best fit for the patient that they're seeing, for a family, friend. And I hope this kind of helps at least get your ideas of what's out there and what we can do. We just as a little segue into everything, we went to a conference last December, and just hearing some of the parents talk about not knowing really how to get their kid the help that they needed. I think this is really beneficial just as an education piece for a lot of therapists, again, like friends, family, whatever it may be, that there's a lot of stuff out there. It just can be overwhelming sometimes to know what might be the right kind of level for them. So things that we are just going to kind of go over today are just different levels of care defined. What are some interventions that can be provided, and how can we assess for an appropriate level of care referral? So to start off is just kind of some facts that we were given by NAMI. So only 43% of adults with mental illness seek services in a given year. 64% of adults with severe mental illness seek services annually. 51% of children and adolescents seek services, and white populations are 20% more likely to seek services. So we got this off of this kind of flyer, which is showing really that's over half of the adults who are struggling with mental health aren't necessarily seeking services, especially when it comes to adults with serious mental illness. They might need a little more than just an outpatient care level provider. They might need a little more supervision when it comes to getting their medications. I think the biggest takeaway that I saw on this flyer was the average delay between symptom and onset and treatment is 11 years. If you're like really thinking about how long 11 years is and how much can happen in 11 years before someone is seeking treatment, that's an immense amount of time. I think some of the biggest things is when they start calling around to hospitals. They're just kind of, a hospital might say, well, you don't really need this, try this, or someone else might say, no, you're not really a good fit for our facility, try this one. And it gets really tough for someone who is struggling with depression or anxiety to have to keep making phone calls. And actually, our facility has started more of a warm handoff type scenario where a lot of therapist office can give us here at Aspen Grove a call, and they can let us know that they have a patient that they're seeing right now and that they need some maybe higher level of care at that point. So it helps facilitate more of a warm handoff saying, yes, I have this patient, I'd like to give them and put them in your care. We can let that therapist know that, yes, this patient came and they were admitted, kind of give that therapist an ease of mind to make sure that that patient is safe at that time. So I think a lot of it is when patients do start to try to seek treatment for themselves, that sometimes it's almost a little overwhelming, and then they just wait, and they wait too long, or they wait, just never really kind of try to find those services that they need. I think it's really interesting that some of the other sorts of populations aside from white adults are seeking treatment. We can see a lot of kind of decrease in the other people who are seeking treatment. So I think this is a really good flyer to kind of just keep in mind when we're thinking about levels of care and what population we should be targeting when it comes to letting people know what's out there. So some of the key points of responding or understanding levels of care is just that it's crucial and it's important to patient and obviously provider satisfaction. Someone who's coming in, just for a typical like hospital admission, if we are admit someone who doesn't really need this high level of care, it could be pretty detrimental to their mental health because they didn't need this 24/7 supervision. They didn't need to be on a lockdown unit. They didn't need to have, a nurse checking in or a tech checking in on them every 15 minutes. So I think one of the big things about understanding what is an appropriate level of care is because admitting them to the wrong level of care can be really hard for them moving forward. If they feel like they were put in a situation that they felt really uncomfortable, they might be a little bit more scared to speak up in the future when it comes to, having maybe intermittent suicidal thoughts or having increased depression because they might be scared that they might get locked up again or they might have their rights taken away. So we have to take it very seriously, understanding what might be an appropriate level for them to go to. So the next point is barriers to clinical progress are often the result of not having the right level of support in proper clinical setting. Again, it kind of just goes back into making sure that even after, say, they left an acute setting, that we're setting up those aftercare appointments with the appropriate people, whether that just be outpatient, residential, day treatment. There's a lot of options out there, and what we have to figure out what is going to be best and most successful for that patient moving forward. This also kind of touches base between striking a balance between the need and level of intervention that can lead to better outcomes. We have a lot of services out here in Utah where we have mental health authorities, which I came from Florida originally, and that's something that Florida did not have. And I think it's been really great out here because it's able to connect a lot in the community and making sure those people who are needing more or extra care do have the ability to get that support that they need, whether that be following, someone with the same clinician weekly, living in one of their support housing, whatever that might be. But this the intervention, like when mobile crisis outreach team goes out and they kind of are the ones determining, does this person need inpatient? Does this person need a referral to a lower level of care, basically? And sometimes that can be really scary for a lot of people because a lot of times the police can go out and also be there. And a lot of times police are triggers for some patients. So kind of making sure that when we're responding to a crisis call or we're responding to a patient who is needing some sort of mental health intervention, that we're appropriately responding and kind of appropriately assessing them so we don't give them kind of a hard time, basically. So the next point is just kind of the levels of care that we're going to be talking about today. As you can see, this is kind of somewhat listed from least restrictive to most restrictive. So the first one is traditional outpatient level of care. We'll just kind of start there. So the traditional outpatient level of care is probably what a lot of people would think of when they hear just an outpatient therapist or an outpatient medical provider. A lot of this may seem like someone seeing their therapist, an LCSW, CMHC, whatever it may be, as a talk therapist. And a lot of this can be once a week. A lot of this can be every other week or maybe once a month, depending on the acuity of the patient. But this is the least restrictive. So this is typically for patients who are a little more stable, probably not endorsing any suicidal thoughts, or if they are, it's very fleeting, if at that. They can just basically be managed on an outpatient level. No one needs to have constant supervision on them. They are able to stay safe within their own home, anything like that. This also encompasses like medication management with a psychiatrist. In Utah, I know a lot of people that we see that come to the hospital have not necessarily a psychiatrist that they're seeing because they are pretty limited out here. So This can be their primary care physician. This can be a physician's assistant. This can also be like a nurse practitioner who has their psychiatric degree. And, you know, those are all good people, but they're managing their medications. They're able to kind of make sure that even if they're doing changes on their meds, that that person, again, is still somewhat stable, not someone who's necessarily going to have a really hard time during that time period. This also includes group therapy. So some people just don't love doing maybe one-on-ones, so they can go to like a group therapy. This is like also like support. If you go to support groups, it helps kind of just, again, it's the lowest level, not necessarily anyone who is going to be needing extra care. And usually, like at the note that said at the bottom, they're usually done in about an hour increments. So it's not going to be a majority of the day. It's not going to be anyone who needs a lot of care or attention. It'll be something that can be kind of talked about in an hour, wrapped up in an hour, and it's something that professional feels comfortable with letting them leave and go home. So these are just some of the reasons why we would refer someone to an outpatient level of care. It usually is maybe someone's having small, minimal like deterioration in their levels of functioning. They might have some hard time maybe focusing on work. They might have a hard time dealing with relationships, maybe not wanting to leave the house as much, or they're having some struggle with just increased depression and anxiety. But they're not having suicidal thoughts. They don't want have any thoughts about wanting to hurt or anyone else or themselves. And this can be for such a wide variety of things. There's so many specialists in the community. There's, you know, trauma therapists. There's people who focus on LGBTQ issues. There's people who focus on if you're having problem, maybe like making friends or social anxiety. I mean, there are so many reasons why people see outpatient therapists, and I think it's just great because you can see anyone that you need that might be more specific to what you're struggling with. And again, at the bottom, it's just kind of like reminding, the big thing is the patient is safe at home. They're willing to come and participate on their own free will. And they might have like good supports at home. Even if they don't have good supports at home, they're kind of willing to engage in that treatment to make sure they themselves are getting their own appropriate care. So the next one is intensive outpatient. This is a step up from outpatient, and it's usually referred to as IOP. So this one usually occurs about 3 to 4 days a week, and the sessions can last anywhere from about 2 to 4 hours. They usually are in a group structured setting, and they usually last probably about, like on the PowerPoint, it says about 6 to 10 weeks. The other thing about outpatient I didn't really touch base on is there's not usually a specific time frame always set. I know that sometimes insurance has a coverage of maybe 20 sessions, but really someone can be seeing an outpatient therapist for many years, and it might be something like daily check-ins. This helps keep them on track or whatever it may be. When you kind of move up on the level of care, it also kind of gets more on a time frame basis, because in reality, we don't want people to have to go to a more restrictive setting for a long period of time. We want to be able to treat as intensely as we need to, and then maybe step them down to the next lower level of care. So kind of going back to IOP, it runs for about 6 to 10 weeks. A lot of it is going to be focused on a specific like topic. So there might be a lot of cognitive behavioral therapy. There might be a lot of DBT, a lot of focusing on coping skills, how to manage stress, improve communication. There's a lot of things that they can focus on. Again, like here at Aspen Grove, we have an IOP that is basically trauma focused. We also have a generalized more IOP for anxiety, stress, and depression, where it kind of focuses a lot on managing your coping skills, managing your negative thoughts, and then obviously the trauma-informed IOP will be more honed in on focusing on trauma response, how to kind of deal with whatever you're going through. So the thing that's nice about IOP is a lot of them are offered more in the evening times. So this allows the individual to be able to, yes, attend work, attend school. If they're an adolescent, they might go to school during the day and then have IOP during, 6 to 9 or 5 to 8, whatever it might be. So it's nice to be able to have this and then be able to still kind of go on with your daily life and not have any issues there. Some IOP groups do have like a provider that kind of goes around and touches base with them. A lot of the times, though, we always recommend that that person is already in a medication management with maybe their own provider or maybe a provider within the program. They don't necessarily offer providers that do medication prescribing with IOP. It's primarily focused on just therapy. So we do always suggest that that person is probably in a medication management with another like provider as well. Kind of going on for the assessments, what are you looking for when it's an IOP? This is basically if you think about just maybe a little bit step up above outpatient. So that patient might be exhibiting really tough depression where maybe it's affecting them a lot more than a lot of people are normally dealing with depression. Maybe they're having a hard time going to work and getting out of bed. And it could look like someone who maybe is still going to work, but maybe they're missing 1 or 2 days every single week because of their depression or because of their anxiety, that they would need a little bit of a step up than seeing someone for 1 hour once a week. Again, this patient should still be safe to go home. Family shouldn't feel like they need to watch them, or family shouldn't feel like they need to have like multiple check-ins a day to make sure that person is still safe. That's where it kind of gets up to maybe a little bit more intense treatment that person might be seeing. So after IOP, we have the partial hospitalization program, or a lot of people call it PHP. Some other places refer to it as a day treatment. And this is, again, another step up from IOP, primarily focusing on therapy. So a lot of people are looking at about 5 to 7 days a week, and they'll be there for about 4 to 6 hours a day. A lot of it is going to be group therapy still as well. And a lot of it will be, again, kind of focusing in on a certain topic, whether that's, again, coping skills, or if it's maybe trauma, bipolar, anxiety, depression, whatever that might be. There are some, I know with adolescents, they might try to include the family at some point as well, just to check in and see, what's going on with them at home. Have you noticed any different behaviors? What are some things you can do as a family that when this patient is, kind of expressing, sadness, anger, whatever it might be, to make sure the family is all on the same page, that they're not unintentionally making things worse for the patient or for themselves. This will likely include a psychiatrist and a medication evaluation. It's not always with every program, but they do try to, especially with day treatment, if they're really focusing in on the individual themselves, that they might have a psychiatrist that's also following that patient while in PHP. A lot of people do end up stepping down from acute psychiatric inpatient hospitalization to a PHP level of care. It's important that when you come from like almost the most restrictive setting that a person can get in psych to a less restrictive setting, but still pretty intense, that it helps kind of transition them from being inpatient to, again, now kind of becoming a part of more function in society, being able to commute from home. not having that constant supervision, but still feeling like they're getting a lot of care all at one time. So assessing what would it look like for someone who needs a PHP level of care. They're probably experiencing some more moderate symptoms, and maybe they're at this point they're barely going to work, maybe at most once a week. They have probably pretty poor relationships. At this level, sometimes people do have intermittent suicidal thoughts. They're not necessarily having them all day, every day. They might have them once a week, they think about it, but have never formulated a plan. They have never had any sort of intent that they were going to hurt themselves. They really just maybe had like a thought about, I wonder what it would be like if I didn't wake up. But they're not doing anything, they're not taking any steps, they're not planning anything that is actually going to hurt themselves. But this is one of the next step downs from an acute patient setting. So it is very intense for a lot of people because you're going for almost like a full work day, but you're receiving therapy and you're doing it 5 days a week. So these patients are going to be a little more acute than anyone else on an outpatient setting. This is pretty much the highest level of care you can get on an outpatient basis. And without being already admitted to maybe a residential service or a acute care setting. So this just requires, again, more intensive medical supervision. A lot of people will step down from acute care to PHP to IOP to outpatient. So those are kind of the levels that they go in. So the next one is kind of just
Rachel, before you go on, sorry to interrupt. We just have a couple of questions in chat. So Katie was asking, I think this is a question, PHP, does it include psych evaluation?
I think it depends on the facility. There are going to be some facilities that do a special sort of psych evaluation for that. A lot of facilities, like I know here, we usually just do an assessment that's done by a clinician to see if they would meet what we deem criteria or that moderate to severe level of depression, not necessarily a psychiatric evaluation, but I'm sure there are some facilities that have that there.
Great. And then another question, Matea is asking, does Aspen Grove offer all levels of treatment? I know we're still working along the continuum, but I guess I think that's what they intended to ask, just if we offer all levels of treatment.
Right. We get almost everything aside from probably residential. And we used to have someone who worked under us for medication management, but they now kind of branched off. But we work extremely close with them. We refer a lot of patients from acute care inpatient to follow up with them outpatient. So we do have IOP. We have a women's trauma IOP and we have a just normal IOP. We have a partial hospitalization program that is for women only, mainly dealing with depression, anxiety, I think along with some trauma as well. We have an acute inpatient setting, which is probably our most, probably our biggest part of our hospital. That's primarily what we function as an acute inpatient. And so basically almost everything except probably residential that we offer here. And Joseph is really great too about if there's any other questions about what kind of we offer, how to get referrals in here. He would be a great question, or he would be a great person to ask, but you could also always just call. We're open 24/7. I have staff in admissions 24/7 who can answer any of those questions. 2 o'clock in the morning, if you're having a crisis, you can absolutely give us a call. Okay, is there any other?
One last question regarding insurance. Does Aspen Grove accept all payers and unfunded patients?
Yeah, so I can speak primarily for our acute inpatient. We pretty much take every insurance. We take Medicaid, Medicare. We take almost every private insurance. And even if we're not in network, we do work really hard on getting a single case agreement. Our business office is amazing at keeping in contact with insurance companies and making sure that we kind of get the best rate for the patient. For IOP and PHP, I'm not entirely sure which insurances are covered, but I know a lot do mainly commercial insurances. I think we can try to possibly work with some Medicaids depending on the person themselves and kind of where we can get with that. But from an inpatient, we also take a lot of people who don't have any insurance. That's not really what our focus is here. We want to make sure that we're just serving the community the best that we can. We have a really good team that helps get a lot of people on Medicaid. I would say probably 50 to 70% of people who come in self-pay get enrolled on Medicaid while they're here, and we can build that way. So the only thing I would say is for detox, because it's not an intent considered a under EMTALA like a psychiatric emergency, that we do require insurance or some sort of payment for detox. Other than that, we are very open to helping anyone in a mental health crisis, regardless of their ability to pay. Okay. All right. So the next one is the community integration program. This is more going to be basis for helping people who maybe need that extra care. A lot of the big definition that I was able to kind of look up and find is community integration is a way to ensure that all people have access to the full spectrum of social, educational, and professional opportunities. It involves ensuring each person with a disability has the opportunity to pursue their interests, desire, and goals. So this can range from a ton of things. This can range from individuals who have severe or persistent mental health issues. This can range to intellectual disabilities, maybe medical disabilities. This just helps a lot of people who need that extra care, maybe getting a job that's suitable for them, maybe getting their medications and making sure they're taking their medications correctly. Maybe just activities during the day, like they might have full-time, or they might have caregivers who work full-time and they need someone to help take care of them throughout the day. And that might be just taking them to different activities. It's just a way to support people who kind of need that extra support on an outpatient level. A lot of times too, we get patients who are civilly committed, which basically means that they need some more intense care, whether that be inpatient, outpatient, state hospital, PHP. So this will also kind of be involved with that, making sure that they're getting their medications, making sure that they're going to their treatment they're supposed to, just making sure that they're able to kind of function at a lower level of care. Because as I said earlier, the ultimate goal is to have people in the least restrictive care possible. We don't want to have to force people to stay at a high level of care all the time. And that's why once they get stabilized, we try to move them down, whether that be IOP or PHP or whatever that looks like. So we always want to give people the freedom to be able to do what they need to do, live their life, and make sure that they can get the support that they need. So that's more the community integration programs, just kind of giving those social supports that other people need and help them in a way that is supporting them so they can live their life to kind of the fullest extent without having a lot of intervention. Again, some people unfortunately need a high level of care, and that's kind of where we'll talk about like the state hospital and things like that. But I think our goal is, as a mental health community, that we want to be able to allow people to have their ability to live their life the best that they can. So the next is a residential level of care. This is what we call basically long-term inpatient care. So this is anyone who's going to live at a facility. It's usually more than 30 days. It could be 30 days or plus. This one encompasses so many different populations, because this can be rehab level for For adults, for detox, not for detox, but for substance abuse. This can be for adolescents. This can be for adults with just mental health disorders. There's a lot of different things that kind of can go under the residential level of care umbrella. The patients will be living at the facility, so this means that they're not going home and coming to like an outpatient or an IOP or a PHP level of care. They're going to be staying there. They might be getting like IOP treatment and might have groups 3 times a week, but they're going to be residing within the facility. So that means nurses or technicians are going to be watching and monitoring them. They're going to have their medications controlled. They're going to be seeing a doctor probably at least once or twice a month, depending on how much stability they need. For some of the adolescents, a lot of the residentials will include schooling because they can stay there for a pretty extended period of time. We want to make sure that they are able to get the treatment that they need and not fall behind on school as well. Any medical care too, they'll receive there. A lot of the things will include individual, group, and family therapies. They'll probably focus on negative thinking, cognitive behavioral treatment, coping skills. A lot of them will have also ways to be able to integrate back into society. So even at a residential level of care, they might have levels within that residential where they might start off at a really acute setting, and then they might transition to a less acute setting within that residential, and then maybe another step down where they might not have as intense therapies. It might be more like, okay, you can have a job and do this, but then you're going to come back to the residential or whatever that might look like. So within that residential level of care, there are also little levels that maybe they have goals to reach, and that's kind of when they can determine when they're safe to leave the facility. These residentials can be locked or unlocked. I think it's going to depend on the acuity that residential is serving. Some of the facilities that are housing more acute patients or patients who might be a little more unsafe, not necessarily there voluntarily, might be in a locked facility. And I think a lot of unlocked or like rehab facilities for those with substance abuse issues, because a lot of them, you need to be willing to participate in your treatment in order to be there. So a lot of them are going to be unlocked facilities. So when you're doing an assessment for a residential level of care, kind of what are you looking for? This is going to be close to acute level. This is just going to be a longer term for acute level. So pretty severe inability to function in your day-to-day life, probably not going to school if you're an adolescent, probably having some behavioral issues where it's not listening to parents, maybe breaking the laws, stealing, anything like that. A lot of the patients that we see too here at Aspen Grove, and then we will refer to a residential setting, will be already in some sort of like IOP treatment or outpatient treatment, and that clearly isn't working for them. So a lot of the people who are receiving treatment on an outpatient level and continue to decline, that's a huge indicator that that person might need a higher level of care. Because if they're already participating in outpatient and they're already participating in medication management, and they're still having maybe increased suicidal thoughts, they're still having behavioral issues, that just might be the next step that they need, is a higher level of care. And for residential, a lot of the, at least detoxers, this might be an alternative to criminal incarceration. We try to give them obviously a chance that, to turn their life around if they'd like to receive treatment, kind of address any needs that they have. We want to send them in treatment before we send them to jail. So we'll get a lot of people who are on parole or who are facing charges for possession or anything like that. And we want to try to help them as best as we can before kind of letting the system take a hold of them, unfortunately, which happens a lot. Okay, so acute psychiatric hospital level of care. This is kind of primarily what we do here at Aspen Grove Behavioral Hospital. There are kind of several across the state of Utah that also have similar units. We are a freestanding psychiatric facility, so that means we primarily focus on psychiatric conditions over maybe comorbidities with like severe medical, someone who might need dialysis or extreme wound care, anything like that. It's something that we wouldn't be able to do here, but there are facilities who are within a medical hospital who are also psychiatric and lockdown that they could help in conjunction with severe medical treatment. So the acute inpatient is basically focusing on people who are a danger to themselves or to others. This can look like suicidal with intent or plan. This can look like a post-suicide attempt that was unsuccessful. This can look like someone who might be homicidal or threatening to kill family members, friends, other people. And this can also look like active psychosis, increased manic behavior, out of touch with reality, basically anyone who is not able to deem that they're safe right now in society. So we'll get a lot of patients who are psychotic. They might not be suicidal or they might not be homicidal, but they have severe delusions to the point where maybe they're not eating because they're paranoid that someone's poisoning them. They might be manic to the point where they just have bought 7 cars and they're not sleeping and they aren't able to make a rational decision at that point, and they need some sort of intervention that's going to help them. It's usually a minimum of 3 days, but I would say we err more on the caution of around 5 to 10 days for medication stabilization. The big thing that we're going to focus on an acute level of care is going to be medication stabilization. Unfortunately, we do have, and we have group therapy every day. We do have a therapist that you can meet with for family sessions, but for anyone who's in this profession, a lot of people know that therapy is going to be more for the longer term treatment. When you want that stabilization, you want to make sure that person's safe. We're going to really focus in on that medication. So this is probably the only level of care that you will meet with a psychiatrist or a doctor every single day, that you are here to make sure that you're safe, the medications are working, that maybe if you're having a weird reaction, you can let them know so they can change it. And it's great because you are monitored by a nurse 24/7. So if you have any sort of reaction that's negative, someone is right there to help kind of combat that, give you something else, or whatever the treatment might be. A lot of the kids have family sessions prior to discharge, just because there are people who have never had this experience, and they might not know what to do with someone coming out of the hospital and what kind of they can do to help that person. So a family session prior to discharge is just to be able to make sure the family's on the same page. We set up these appointments for them to see a therapist or a psychiatrist, which by law, we're supposed to have a follow-up appointment within 7 days of your discharge with both a medication management provider and a therapist. So we'll be able to get that kind of going and make sure that the family members know that information so they can get their person to kind of that next level of care that we've set up for them. Again, so what does that look like? Suicidal, maybe they're self-harming where they're intentionally cutting themselves. Any active psychiatric disorder with a potential to interfere with treatment of serious medical conditions. So maybe they've stopped taking care of their diabetes because they believe that medication is poison or whatever it may be. For detox, this is going to be, at least for our facility, we detox from alcohol, benzodiazepines, and opiates. So I know that a lot of people use meth or cocaine, but medically, there's not a medical detox from those. So anyone who, like I said, is detoxing from the alcohol, benzos, or opiates, we put them on a taper and kind of monitor their withdrawal symptoms to make sure that they're safe. This will again include severe deterioration, so they might not be functioning in their life at all. We'll focus on medication stabilization and any like behavioral control or interventions that's needed on that level. The acute care medical hospital. So this is really just like any ER. Like I said earlier, we're a freestanding psychiatric facility. So if someone is calling us and they're saying that they just overdosed an entire bottle of medication, more than likely we're going to let them know that they need to go to an ER to get medically cleared first. We don't have the capacity to do labs right away or have a medical doctor see them like they do in the ER, or take like a CT scan, an X-ray, anything like that. So that's that acute care medical setting, medical hospital setting, anything that might just be needing immediate attention to make sure that person is safe medically. So that they might draw labs right away, complete an EKG. If there's some sort of altered mental status that someone is exhibiting kind of out of nowhere, they might do a CT scan or an MRI. And this just lets a lot of psychiatric facilities know that, hey, there's not anything medically wrong with this person, and there's not anything medically contributing to what's going on with their situation. And we think that it needs a psych referral. And that's great for a lot of psychiatric places to know, because sometimes someone will be 50 years old, have no history of psych, and all of a sudden become psychotic. And this could be from a UTI. This could be from a tumor in the brain. This could be from, wacky blood levels. So this just allows a lot of psychiatric to know that, yes, this is truly a psychiatric emergency over kind of a medical emergency. And this is just some, kind of what is surrounding for a referral to the ER. Like I said, any like overdose, maybe self-harm that does require stitches or sutures, anything like that. Some people have a lot of non-compliance with medications for their chronic conditions, such as diabetes or seizures, or, might be MS, whatever it may be. So this kind of lets people get that initial dose, and then we can help continue that medication as they seek the acute care. And this one does, so the acute care, like the ER, a lot of people go to the ER for their level of care assessment. We do free assessments here as a level of care. So sometimes it's a lot easier to come here and skip the ER as long as there's no true medical emergency. And we can refer to IOP, we can refer to PHP, we can refer to outpatient, whatever that may look like. So this is also what the ER does. Sometimes it's just nice to skip the lines and, come straight to the source. The other thing that they did, that was on here that wasn't fully mentioned, there's a subacute care. This is kind of like that middle ground between acute inpatient and probably partial hospitalization. So something like a vantage point down here in Utah County. There's one up in, I believe, Salt Lake County called Farmington Bay. It's a little more intensive than a PHP. They'll stay the night, but it might not be a lockdown facility necessarily. And it might just be someone who needs some monitoring for a few days, but isn't to a point where they're gonna actually try to kill themselves at that point. So that was kind of like one of the things that I forgot to mention through these slides as well. So just when we're kind of thinking about what are you looking for in a level of care assessment, Aetna, who's a huge insurance provider, kind of has deemed these 5 things. One is the acute dangerousness. Are they harm to themselves, or are they harm to other people? Are they in touch with reality? What does their functional impairment look like? Are they able to work? Are they able to go to school? Are they able to have relationships with people? Or are they completely withdrawn, not able to get out of bed, not able to do their ADLs, maybe having severe like isolation, anhedonia, anything like that. Mental status, are they disoriented? Do they have altered mental status going on? Are they reporting auditory or visual hallucinations? Do they present as very withdrawn, depressed, flat, blunted affect, or are they presenting with euphoria and flight of ideas or racing thoughts? Psychosocial factors. Did they just get a divorce? Did they just lose their job? Did they, just have a huge family argument? Or, what is going on in their psychosocial that might be contributing to this depression or anxiety or suicidal thoughts? And then anything like additional, a lot of them are just kind of like, do they have prior treatment history? Have they been responsive to treatment history in the past? Have they had previous suicide attempts? Have they had previous self-harming attempts? What are their internal kind of resiliency? Do they have support at home with other people? And do they have a past history of like aggression or violence? So what are anything that can contribute to either worsen their dangerousness or kind of bring them back down to, okay, they've never had a suicide attempt in the past, so that might be not as big as a threat as someone who's had 5 in the past. And then this is more for the withdrawal symptoms. So again, are they acutely intoxicated? Have they been using alcohol, benzodiazepines, or opiates every single day? That they're going to come off and they're going to have some pretty severe medical. And this can look like a lot of nausea, diarrhea, sweating, elevated vitals, heart rate, blood pressure, anything like that. If they have a comorbid medical issue, that's going to be even more of a reason to come inpatient. People who are detoxing from benzodiazepines or alcohol are at a high risk for delirium tremors, which can be psychosis. A lot of them can have withdrawal seizures, which is extremely dangerous. So we always prompt people that it's important to make sure that they're coming in for a detox treatment. The readiness to change. I think anyone who kind of works in an inpatient setting or has any sort of involvement with substance abuse know that they often have relapses, that they often feel like they might be ready, but won't have the support at the end, which causes relapse. Some of them are being forced to come in for detox because they have a court order. So there's a lot of things that are going to contribute to what's what level of readiness are they at to change. And then recovery and living environment. We want to make sure that they have that support post discharge, whether that looks like residential treatment, IOP, PHP, whatever that might be. So overall, these are the big things that we want to look for when we're kind of looking at that level of care. What is their risk of harm? How are they functioning at home? Do they have any comorbidities? Do they have that emotional support? Do they have that environmental support, or is it very stressful? Do they not have any financial means? Did they just lose their job? Have they been in treatment before? What has that looked like for them? There's a lot that go into kind of the level of care. I hope that kind of going through this shows that, there's a lot out there for people to get the help that they need. And sometimes it just depends on how they're presenting what might be the most important way to get them that help. Other than that, that's kind of the main thing. Is there any more questions or comments, thoughts?
I owe Kimberly an apology. I had a question in queue. I think you did answer at least the first part of the question, which was whether we do take patients from regional hospital ERs. The second part of the question was, what does a day look like in our hospital setting? She says that groups or clients have mentioned that sometimes groups get canceled. Is there a lot of downtime, or maybe what would constitute canceling a group in a hospital setting?
Right. And that's a great question. I think a lot of it is going to depend on staffing. That do we have the ability to complete a group? They are typically required to have some sort of daily therapy group. We also have a nursing group that come and they do that daily as well. They also have a mental health tech group that kind of goes over the unit rules, the scheduling, and like any programming that's going to happen. Hopefully it doesn't get canceled that much, because it's really not supposed to. They're supposed to have groups every day, especially therapy groups. Here at Aspen Grove, and I can only speak for our facility, we have an amazing specialty unit. So we really try to keep, we have an all women's unit where we try to focus on a lot of mental health and trauma in that group. We have a primary detox unit with some mixed in with some low acuity mental health, which means more just like suicidal, no one that's presenting with active psychosis or aggression. And then we do have a kids and high acuity unit, which the kids are just anyone 17 to 12 years old. And then high acuity is anyone who's experiencing psychosis. They might have some aggression as well. And those groups are supposed to be geared to each unit that they're on.
Here's another question that came through chat. Let's see. Does Aspen Grove ever work with court-ordered individuals?
Yeah, we do. We get a lot of patients who are under civil commitments for mental health. I haven't seen too many court-ordered like detox patients. But if they met the criteria and they had the appropriate ability to pay, we could definitely work with someone who was court-ordered for detox. But for mental health, yeah, we do get a lot of court-ordered under civil commitment. Our therapists work great with the courts down here in Salt Lake and in Utah County. So that wouldn't be an issue for us. As long as it's an appropriate patient that we can treat here, them being court committed is not an issue for us to handle here.
Brittany, I think it was. Yeah, she was just mentioning that Farmington Bay is a detention center. She said that there is a JRC in Salt Lake City and a JRC like facility in Layton, but Davis County does not currently have one, she believed, for anyone who had been asked.
I'm just seeing John's in the chat too. It looks like in 2020 it was converted to a receiving center model.
Okay.
And the only reason I knew about that is because a caller said that their daughter was at Farmington Bay, which was essentially like the vantage point. And that might not be information that's totally out there yet, because I actually had no idea about it until someone called me and told me. So it looks like hopefully they're moving in the right direction to get that area the support that they need.
Great. And then Eduardo had asked if the assessment tool, and I think he's referring the one that was on Aetna's page, I believe, if it's for both adults and youth. It was one of the last couple of slides, I think.
Yeah, I think so that's their level of care assessment tool, and that can be kind of generalized to everyone. But a lot of insurance companies are going to the CalLocus, which is child and adolescent level of care utilization system review. Pretty similar. They can probably just consider a little more about the adolescent's environment. Are they in a safe environment with supportive parents? Are they in a safe environment where they're not being abused at home? I think it will focus a little more on the external factors, where some of the adults, it'll focus a lot on internally. Have they been trying to, kill themselves? Maybe external and job related financial situations, divorce. And like I said, the adolescent might be, how's their relationship with their parents? And I know this is not necessarily a question, but I think it's important that I kind of touch base that Aspen Grove has been moving to kind of serve a lot of the rural hospitals down south and up north that don't necessarily have a giant support in their ERs. We do a lot of telecrisis evaluation level of care assessments, where we are seeing patients via Zoom or telehealth to kind of determine if that person from the ER needs inpatient level of care, or if they can be referred to an outpatient level, whatever that might look like. And we have a lot of job openings for that right now. It's a very kind of laxed PRN. You kind of just put in your available time. We have 4 shifts throughout a 24/7 or 24-hour period. And, the pay is great. You kind of pick up when you can. So if you have any more like questions, or if you're interested in maybe doing that, I can type in my email on the chat here, and I would be happy to, and Joseph's already beat me to it. So, you can definitely email me if you have any other questions or if you want to find more information about doing that. It's a great practice for people who are kind of trying to learn what might be considered inpatient or outpatient. Okay.
Thank you again for your attendance. This has been a lot of fun, very informative, and thank you, Rachel, for the time and the
Thank
effort that
you.
you put into this presentation. This is a wealth of information, and I know I keep it handy, so I appreciate that.
Thank you, everyone.